Hello, my dear students. We're going to start focusing on some immune disorders, starting with hypersensitivity, which will nicely transition into autoimmunity. The two of them are very related. So let's make sure we can distinguish between hypersensitivities and autoimmunity. They are related, but there is also a distinct difference, and that is that a hypersensitivity is really just an exaggerated response by the immune system to something rather harmless. So it's as if the immune system sees the harmless cell or chemical as something that is very foreign and therefore triggers an immune reaction. Hypersensitivities can lead into autoimmunity, as we will see. And this time, what happens is that there is going to be literally a breakdown in the immune system, in the sense that the immune system really cannot distinguish anymore between what belongs to this person's body and what does not belong to this person's body. In other words, it's going to think that a self cell is the same thing as a pathogen, just to give you an example. Hypersensitivities are caused by either inhaling the harmless object or harmless cell, by eating it, or we might touch it with our skin, or it might come into contact with another mucous membrane, like in our nose, our eyes, or even via the anal canal. There's various ways. It might also be that it was injected and then trigger a hypersensitivity reaction. As mentioned, there are 4 different kinds, and the kind that occurs is going to depend on what kind of an immune response that occurs. For instance, are antibodies involved or not? And also what the location is of the antigen, and which that seems like a strange way of uh, creating a classification within the hypersensitivities. But for instance, an antigen might be might be part of a cell that is just flowing around freely in the body, or not. It might not be attached to a cell surface. It might just be an independent type of antigen, not associated with a cell at all. Just to give you some examples of what we mean by different locations of antigens. So we have 4 major categories of hypersensitivities, and just a warning, within each one of them we have subcategories, sometimes many. So they're usually numbered by means of a Roman capital letter: type 1, type 2, type 3, type 4. We can also classify these hypersensitivities based on how fast the response occurs. So we have the first 3 that are immediate responses that occur like almost instantaneously or just within a few hours, while the delayed ones take a while, sometimes days, before a response is generated. The delayed one, as you can tell, is your only type 4. The immediate ones, the first 3, are all going to involve some kind of antibody or antibodies, despite their nicknames. So type 1 is referred to as IgE mediated. Type 2 is also antibody mediated, but not via IgE. In the case of type 3, we're going to see that together with the antibodies, complement gets involved as well. So all of these 3 see the involvement of antibodies, but typically we're going to see something else helping out the antibodies. And then, as I said, in the type 4, we don't have any antibodies, and it is T cell mediated instead. Some people like the acronym ACID. I listed it here because in the type 1 type of hypersensitivity, that's where the allergies belong. Type 2 involves your cytotoxic reaction. Particularly, we're going to see that one of the subcategories includes or uses the natural killer cells. That's where that cytotoxic comes from. In type 3, we're going to see these immune complexes that precipitate and create havoc, especially in the cell membranes of, I'm sorry, in the basement membranes of blood vessels. I'm not particularly, oh, and then finally, type 4 is delayed. I'm not very dependent on that mnemonic acid, but it might help some of you. Um, I have to depend on other methods of remembering the 4 different types of hypersensitivity. So after you've studied each one of them, see if you can come up with a way for you to remember which one is which. So let's get started here with our type 1 hypersensitivity. And this is where your immunoglobulin E plays a role. So when your B cells differentiate further into plasma cells, they're going to have to go through class switching in order to end up with producing IgEs. So keep an eye out for that. So this is where we have our traditional types of allergies. In this type of hypersensitivity, allergies towards the pollen in the air or dandruff, perhaps even medications such as penicillin, foods such as peanuts, etc. Now, there are 2 subcategories. One is called atopy. The other one is called non-atopy. And I might be kind of exaggerating the pronunciation. I'm sort of doing this on purpose to help you remember what these stand for. Atopy literally means atypical or out of location. You could argue topic often refers to a space, not a space so much, but a location. So, or uncommon, you could think. And we refer to this also as a local form of anaphylaxis, while the other one is a full-blown, all over the body systemic anaphylaxis, and it's called non-atopy. So these are the 2 we will take a look at. So let's take a look at this diagram. I have a text slide prior to this that explains this whole diagram. Um, First of all, this diagram is going to address the very first exposure to our allergen, for instance, a pollen, right? Or it could be some other chemical in the air that we become allergic to. So most of this diagram, and I'll use the color red, is going to focus on the first exposure. All of this is all what needs to happen during the very first exposure, which we like to call sensitization. So I'm using the red color to represent that. Notice that we have numbers to easily follow this diagram: 1, 2, 3, and 4, all the way to the formation of your IgEs. All of that is happening during the first exposure. So let's go through them before we get to number 5, which is the actual hypersensitivity 1 reaction. So let's say that the pollen is the antigen to create this havoc of hypersensitivity 1, and therefore here we see our dendritic cell, more than likely a Langerhans cell, which processes the antigen the way you learned, and it's then presented by your MHC class 2 to a T helper cell. No worries about whether it's Th1 or 2. We're not going to go into that much detail. You just need to be aware of the fact that it's a Th cell. That Th cell, that T helper cell, will then be able to interact with a B cell that also already managed to connect to that very specific squiggly antigen by means of its B cell receptors that will ultimately, as you know, become these IgE molecules, but we're not quite there yet. So we have this interaction here with all the cofactors, etc., and that's going to trigger the release of all kinds of cytokines, particularly interleukins. You don't have to know specifically which ones. And then this, of course, is going to trigger our B cells to start dividing and differentiating into our plasma cells. We may see some class switching to where we ultimately end up with IgE. Now, these immunoglobulin E molecules are then going to, with their FC region, bind to receptors specific to the FC region. So here of mast cells, or it could also be, this could also be a basophil. Doesn't have to be a mast cell. We're just using the mast cell here as an example. So basophil or mast cells, remember they're stuffed with granules that contain histamine in particular. So here we are, our IgE molecules are now stuck onto our mast cell, and this sensitizes the mast cell. Now, not much is going to happen in this person's body until they're re-exposed to this particular allergen. And then the response is going to be very fast because this mast cell is now, with the help of these immunoglobulin E's, going to be able to bind all of these antigens quite rapidly, go through the process of degranulation, and that's going to lead to inflammation in response to all of that histamine that is released. And histamine is a good vasodilator. Capillaries get leaky, the whole process of inflammation, both the vascular as well as the cellular response. So let's take a look at the atopy form of hypersensitivity. As mentioned before, we sometimes call it local anaphylaxis, and here you get a good feel for what that looks, and we can probably imagine what that feels like. So there's we recognize this as hives, and then a better way of referring to hives is to call it urticaria. Hives often go along with itching, called pruritus. Hay fever is also a very typical result or symptom of atopic hypersensitivity 1. As you can imagine, we're going to see high basophils or high mast cells with a high IgE level in the blood. This is something that tends to run in families. So if perhaps there's a parent who suffers from eczema or allergic rhinitis referring to getting very congested and a very runny nose with lots of sneezing, even asthma, and then we'll talk about latex allergies later as well. This is often seen in families. So I mentioned asthma because it is a very good example of the IgE-mediated type of hypersensitivity, which, by the way, is explained here for the first exposure. So everything we discussed in our diagram is shown in a flow chart here for the first exposure. And then here we see the second exposure with the release of, for instance, histamine. Of course, the granules of both the basophils and the mast cells contain a lot more things, and they're listed here. You've learned about prostaglandins and leukotrienes, for instance, to know what kinds of inflammatory damage they can create. Now, the reason why we bring up asthma is because it actually, even during the first exposure, sets off what we call a late phase reaction with the help of eosinophils. So in the case of asthma, we also are going to be using eosinophils in addition to mast cells or basophils. And they again can go through the process of granulation and create some issues. And this all happens all over again during our re-exposure. Now, the non-atopic IgE-mediated or type 1 hypersensitivity can get life-threatening. So it's a form of systemic anaphylaxis, very common when a person is stung by some kind of a hymenopteron like a bee or a wasp or a fire ant. I always have to carry adrenaline, or you can call it epinephrine, to inject myself in case I get stung by a wasp. Many people are becoming more and more allergic to the natural ingredients of natural latex. We'll talk more about that. Peanuts, shellfish, some people are very allergic to penicillin. And so these are things to keep an eye out for because the results can be lethal, or if caught on time, still very unpleasant. So here you see a poor kiddo with the beginning, or maybe a little bit further along the ways of that systemic form of anaphylaxis. It starts out by, just having the hives and being itchy, but then continual histamine and other uh, chemical mediators are released by our sensitized mast cell, and you see the other ones listed here. Most of those you've learned about. And we're going to see some major systemic consequences. For one, we see systemic vasodilation. And if suddenly all of your blood vessels start to widen, as you can imagine, that's going to cause a rapid drop in blood pressure. Your heart is now going to try to keep up with pushing the blood around in the body, so it starts to beat fast. We call that tachycardia. So when a person has a high heart rate, it's called tachycardia. And because the person's blood pressure is dropping, they get rather lightheaded and feel like they're going to pass out. All of that histamine and all of these other um, mediators, chemical mediators that are being released, are going to cause the branches of your trachea, your bronchi and bronchioles, to start contracting. We call that bronchospasms, so that it becomes very difficult to exhale, which is the problem with asthma. We'll also see, in addition to those muscles contracting in the digestive tract, and so people might have pain in their abdomen. And finally, or one of the other main consequences, there's more, but these are some of the major ones. We might see that the throat starts to swell, and that can lead to the person literally suffocating, which I feel right away when I've been stung by fire ants, for instance, or by a tiny little bee. The inside of my head starts to swell. I kind of go deaf. Then my throat starts to swell. And of course, it's big time to inject epinephrine at that time, or at least supply yourself with antihistamines and then the epinephrine shot. Now, in this day and age, because we use latex gloves and tubing made up of latex, and I'm talking about natural latex. We can now also form an artificial form of latex, but we're talking about a natural form of latex, and I'll explain exactly what we mean by that. Because we use it so much on patients these days, um, and therefore patients are exposed repetitively, they can very easily develop an allergy, which is going to be a type 1 allergy that is really nasty. Um, or it can be a much, much calmer type of allergy, which is the hypersensitivity. For this one, we've known about for a long time. And like I said, it's not that threatening. This one, the type 1 allergy towards latex, is much newer because, again, because of where we're going in medicine. So, if somebody was born with a major medical condition to where they had to have surgery after surgery after surgery during their childhood years, they have been exposed many, many times during surgery, with the help of the surgeons wearing latex gloves, or doctors might have inserted devices inside of them that contained latex tubing, you name it, right? So natural latex is actually made from the natural sap of the rubber tree. And that natural sap contains a protein which we'll refer to as rubber protein. And it's that rubber protein that can create the nasty anaphylactic conditions in hypersensitivity 1 in the latex allergy, I should say. Um, so the way this works with regards to the latex anaphylaxis is that somehow the um, the rubber protein in the latex items is going to make it into the mucosa membranes. Um, so the rubber protein in the latex is going to touch the mucosal membranes, and then the rubber proteins can somehow manage to enter into the body. And as said before, we might start out somewhat harmless with some itching and some um, a little bit of redness, some hives, but this could potentially start going into very nasty consequences with gangrene and the sloughing off of cells and lots of pain. So when I say that the rubber proteins manage to somehow get into the mucous membranes, we're talking like the eyes or the mouth. So dentists can trigger this kind of hypersensitivity in sensitive individuals. Your respiratory tract, digestive tract, urinary tract, reproductive tracts, they're all lined with mucosa membranes. Um, you know, all of these orifices are constantly checked with latex gloves, if you think about it, or might experience the insertion of some kind of a tube that is made out of latex. Now, people may also inhale the rubber proteins because the latex gloves are often powdered, as you know. And when we remove the latex gloves, all that powder flies in the air. The rubber proteins are attached to that, and we might actually inhale that powder with the attached rubber proteins, and again, that can trigger an anaphylactic reaction. So a latex allergy that is a hypersensitivity 1 can be very dangerous, and it's relatively new, like I said, since we have begun to introduce lots of latex containing products on the markets and in medicine. So that wraps up our discussion of our type 1 hypersensitivity. Remember, the antibody that is involved is IgE, and this is what triggers our allergies. Remember, these first three are all going to involve some kind of antibody somehow, even though their names don't always reflect it. Keep that in mind. On the other hand, type 4 has nothing to do with antibodies, and that is a very delayed response. All of these first three are immediate responses.